Okay, well, so I'd like to welcome all attendees to today's Thomas Lecture, which is the annual lecture from our division of rheumatology, allergy immunology. And I'll just mention that this lecture honors Dr. Charles Thomas and his wife, Evelyn Thomas, for their contributions to the rheumatology field. Through their generosity, they've endowed 2 faculty positions, a fellowship position, and a research fund that helps our division accomplish many of its academic goals. So today's talk is going to be on gout, the disease, its management and opportunities. And there are 2 presenters. The first from our division is Nihal Shah, who joined us in 2012 from the University of Pittsburgh, where she did her training in rheumatology. She has developed expertise in musculoskeletal ultrasound, which she uses to help determine prognostic factors in rheumatoid arthritis. And more recently, she's become interested in new treatments and new options for precision medicine in the treatment and evaluation of gout. Joining her is Joseph Roman, who is an assistant professor in the Department of Pharmacotherapeutics and Outcomes Research. He joined the faculty a little over a year ago after completing a PharmD at Oregon State and a PhD in experimental and clinical pharmacology at the University of Minnesota, and has a special interest and is well published in the field of pharmacogenetics as it relates to gout. So without further ado, I'll turn the show over to Dr. Shah.
Okay, good afternoon, everyone. Thanks, Dr. Swartz, for kind introduction. We're going to talk about gout today, the disease, the management, and the opportunities. I'll be co-presenting with Dr. Rahman. And both of us have no disclosures. Why it's not moving? Both of us have no disclosures. So gout is a chronic episodic inflammatory arthritis caused by hyperuricemia and deposition of MSU crystals in joints and surrounding tissues. Let's look at the epidemiology of gout. So it's one of the most common inflammatory arthritis affecting 9 million people in US and about 41 million people in worldwide. If you look at the prevalence of hyperuricemia, it is 21.5% in US. Over time, prevalence of gout and hyperuricemia both have increased in US according to the National Health and Nutrition Examination Survey. And this is likely due to changing lifestyle and worsening obesity pandemic. Gout-associated comorbidities. There is a high prevalence of hypertension, CKD2 and higher, obesity, diabetes, hypertension, MI, and stroke in gout patients. There are several studies mentioning increased risk of cardiovascular disease and related mortality in gout patients. So the causal relationship of hyperuricemia and gout to cardiovascular comorbidities is not entirely clear, but here is the proposed model for it. So patients with chronic hyperuricemia or gout have activation of renin-angiotensin-aldosterone system. There is increased inflammation and oxidative stress leading to microvascular changes and endothelial cell damage, decreased endothelial nitric oxide production, which all in turn leads to increased vascular resistance and hypertension, which in turn increases risk of kidney damage, heart failure, atherosclerosis, and cardiometabolic disorders. Now we'll talk about pathophysiology of hyperuricemia and acute and chronic gout. So hyperuricemia can occur either through overproduction, through purine metabolism in liver, or under excretion either in kidneys or gut. About 80 to 90% of gout patients are renal under excretors, and there are urate transporters in the proximal kidney tubules, in which is responsible for excretion and reabsorption of the uric acid. The uricosuric drugs, which are used for gout management, they block these urate transporters and decreases reabsorption of uric acid in the tubules, in turn leads to increased uric acid excretion. The xanthine oxidase inhibitor drugs acts at this level by inhibiting conversion of the xanthine into the uric acid, and that's how decreasing production of uric acid. This slide reviews the pathophysiology of acute gout flare and the tophus formation. So patients can have hyperuricemia for many years before they develop MSU crystals. And there are factors like temperature, pH, salt concentration, cartilage matrix can affect this conversion of the MSU crystals. The crystals, once it's formed, it can activate macrophages, usually in presence of a secondary signal, which could be a diet-related trigger, in which fatty acids or oxidized LDL through toll-like receptor leads to activation of interleukin-1 beta. This, along with capsase-1 in macrophages, activates NLPR3 inflammasome, which leads to release of pro-inflammatory cytokines, which cause the flare of the gout. There are anti-inflammatory mechanisms involving NAT formation, which leads to degradation of these pro-inflammatory molecules, which in turn leads to resolution of the flare. If gout is not treated and if patients having recurrent flare, they can end up developing tophus or tophaceous gout. So tophus is basically an acute granulomatous tissue in which you have pro-inflammatory mechanisms and anti-inflammatory mechanisms coexistent, trying to contain crystal-driven inflammation. And you can also compare this to PANAS of rheumatoid arthritis. Gout risk factors. Genetics and family history play a key role. There are select drug classes like diuretics, calcineurin inhibitors are important. Diet and lifestyle, patients with heavy alcohol use, patients with high intake of purine foods, or high corn fructose syrup, those are the diets put patients at risk for gout. Select comorbidities, CKD, diabetes, obesity are important ones. Let's look at the clinical manifestations of gout. As we all know, gout comes as an acute flare, and the acute gout flares are basically an episodes of intermittent self-limiting flares where patients have intense joint pain, swelling, warmth, and redness. Pattern of joint involvement. Gout flare usually is monoarticular or oligoarticular. Here you see a picture of gout flare affecting first MTT joint, which is one of the common joint for the gout flare, affects in about 30 to 40% of patients. Overall, lower extremity joints are affected more commonly than upper extremity. Polyarticular involvement in a gout flare is rare, usually seen in patients with chronic tophaceous gout. There's an intercritical gout, in which period between the gout flares where patients have no symptoms of gout. And then there is a phase of chronic advanced tophaceous gout. So if patients are not treated, they can end up developing tophaceous gout, in which you see chronic tophi near joints or tendons, leads to often joint deformities, joint erosions, usually have polyarticular flare, and patients will have symptoms of chronic or recurrent flare. How do we diagnose gout? Clinical presentation is very important, as we discussed on the previous slide. Hyperuricemia or high uric acid level. Levels more than 6.8 milligram per deciliter. The good time to check the uric acid levels is in between the flare, because if you check it during the flare, the levels can be falsely low. So you want to be very careful in documenting hyperuricemia during the intercritical gout. Synovial fluid analysis for MSU crystals. This is still considered a gold standard, in which you will see intracellular negatively birefringent needle-shaped crystals under polarized microscope. Imaging modalities. Traditional radiographs. You can see tophus with underlying gouty erosions on the radiographs. Gout erosions appears as a punched out lesions with overhanging edge, and they're usually juxta-articular in location. They are also known as rat bite erosions. Radiographs are you can say that these are more specific for the gout erosion, but this is not a good modality for diagnosing gout, because you want to diagnose and treat the gout before this develops. So you need to kind of pick these patients early on before they appear on this diagnosis appear on the X-rays. Dual energy CT and musculoskeletal ultrasound are newer emerging modalities for gout diagnosis. MRI is falling out of favor because of non-specificity of its finding for gout and the cost. This slide shows meta-analysis of several studies which looked at sensitivity and specificity of ultrasound and dual energy CT for gout diagnosis. Images here, the ultrasound images here shows gout, tophus, and the double contour sign. So gout tophus appears as a heterogeneous collection near joint or tendon with or without underlying underlying joint erosion. And the double contour sign appears as an hyperechoic line overlying the cartilage. And if you look at the sensitivity for the gout tophus for the gout diagnosis, it's 0.65 and 0.8 for the specificity. The sensitivity for double contour sign is 0.83 and specificity is 0.76 for the making the gout diagnosis. Dual energy CT, you'll see the gout or MSU crystal collection as a green material, and sensitivity of this finding is 0.87 and specificity is 0.84. So if you look at the sensitivity and specificity for both of these studies, it's pretty reasonable and comparable, and it could be a good alternative to joint fluid, or synovial fluid analysis if the former is not feasible or patient declines, or if it's in a joint which is hard to aspirate. Okay, I'm gonna hand it over to Dr. Raman for going over some treatment.
Thank you, Dr. Shah, and I hope you guys can hear me well. Please let me know if I'm too low or too high. So today we're gonna continue on and talk about gout treatment goals, and I really like to categorize those goals in almost three categories. We have the immediate, and we have the short term, and we also have long term. So clearly when we have a gout flare, that's our immediate goal. We want to resolve that gout flare. We want to have our medium sort of short-term goals. We want to prevent more gout flares. And our long-term goal is to really prevent joint damage. So that's really the ultimate goal. And to achieve these goals is by actually maintaining and suppressing uric acid levels below 6 milligram per deciliter. That will allow us to maintain or at least prevent formation of uric crystals. And in some cases, it's probably less than 5 in patients who have advanced form of tophaceous gout. But it's important when we think about achieving those goals, we need to think about the big picture of managing gout, that gout is in the context of the other comorbidities as well. So that's very important because it warrants the importance of making optimal drug selection and definitely making sure that you manage the conditions that also come along with gout in a way that does not aggravate gout itself. With the case of any chronic disease management, it's important to address the lifestyle as part of the treatment modality. Gout is no different than hypertension or any other condition that can benefit from some lifestyle modifications. I'll highlight some of those that are listed here, and obviously some of those recommendations backed by the guidelines that just came out almost like last week. So weight loss is important. We saw that from bariatric surgeries and DASH diet. People who had bariatric surgery had lower incidence of gout flare. People who are adherent to DASH diet had lower serum uric acid levels. As Dr. Shah mentioned, some of the risk factors for gout are alcohol consumption, so limiting those is important. Purine sources, so seafood, meat, red meat specifically, and then limiting intake of high fructose corn syrup. So sugar drinks can make a big impact on minimizing the risk of gout flare. Other things that you can encourage to help with gout management is the probably non-fat dairy product. Studies have shown, although it's not really large studies, but have shown that sometimes non-fatty dairy product can lower uric acid. Increasing hydration is very helpful, especially during gout attack as well too. And some data have shown that uric extracts can actually help with uric acid levels during, in general, but also during gout flare, it can have actually an anti-inflammatory effect. Coffee and vitamin C, there are some data out there, just be familiar with those. But the fact they're not really robust enough to really indicate the use of vitamin C as an adjunct treatment or recommending somebody to consume a lot of coffee to lower uric acid, but there are some data out there. So gout treatment approach, I think when we think about the acute management, we think about the NSAID and colchicine are sort of go-to drug options. You can also consider systemic steroids as first line. but in general, they're not really seen as first line for most patients. But it's not about which one is first line, which one is second line. I think at the end of the day, it should be patient-centered approach. So when you make a decision about which drug treatment to use, I think it's important to highlight some of those elements there that should guide your decision: comorbidities, concomitant use of certain drugs. Clearly, some patients' comorbidities like renal function is important. Patient preference, what the patient used in the past may guide your treatment. And obviously, the drug cost is very important, because at the end of the day, if the patient cannot afford the medication, whatever you do is not going to work. But what are some of the considerations that you should keep in mind as you make a decision about which treatment modality to use for acute flare? For NSAIDs, I mean, there are a lot of NSAIDs out there, and there are really not a lot of differences in terms of which one is more superior, which one is inferior. For the most part, they're all equally effective. Historically, we've learned that, especially from a clinical pharmacology, that probably endomethacin might have some uricosuric effect. But again, that's probably the only key difference about the endomethacin, but equally effective as any other NSAIDs. With the use of NSAID, we have to keep in mind the comorbidities, specifically chronic kidney disease, history of GI perforation, peptic ulcer, established CVD, because those are definitely should guide your decision about whether this patient should be on an NSAID or not. And if patient needs to be on NSAID, I think the option of using PPI, proton pump inhibitor, can be a way to minimize the risk of GI bleeding. Colchicine is definitely, it's a rising star in terms of gout flares management, because we've learned a lot in the last few years about the lower dose of colchicine being as effective as the high dose. In fact, there's a lower risk of side effect with the lower dose than the higher dose. Timing of initiating colchicine is critical. Ideally, you want to initiate that within the 24 hours or even less. But clearly, anything past 36 hours is clearly wasted. So there's really no benefit for colchicine at this point. It's renally eliminated, so people who have some form of kidney function, kidney dysfunction, or declining kidney function, I think that should be kept in mind. One thing about colchicine, that's a CYP3A4 substrate, so there's a potential of drug-drug interaction. We know there's a lot of drugs that are being metabolized by CYP3A4. Colchicine is also a P-glycoprotein substrate as well, so potentially potential drug-drug interaction, so that should be taken into account as you make decisions. And finally, the glucocorticoids are another option to use, again, as effective as colchicine and NSAIDs, but particularly with these particular drug classes, you have to keep in mind the duration of therapy and also tapering the drug. So you use the drug to treat, but also you back off slowly for these drugs. So sometimes it's going to be a while for these drugs to be for the patient to take. Probably preferred in older adults for the reasons that actually NSAID and colchicine might have, you might have a lot of contraindications to use NSAID and colchicine in older adults because of the fact that they have a lot of comorbidities. One of them is declining kidney function. We also know that the metabolic disorders that happen with glucocorticoids or systemic steroids definitely can be an issue. So a patient with prediabetes and having some metabolic disturbances definitely can be basically a red flag for you to initiate this drug or not. And then there are some other side effects with this particular drug class that also need to be kept in mind. So the psychoactive side effects, sleep disturbances can be associated with these drugs. So counseling patients on side effect and also timing of taking those drugs, so for the morning versus at night, might help a bit. And if patients are not really able to tolerate any oral treatments, we have some acute gout flare management options. So the one that obviously we have some data on right now is the interleukin-1 inhibitors, so canakinumab and anakinra. Studies have shown that they have been very effective in patients who have frequent gout flares, over obviously defined by 3 or more over last year or 12 months. But generally the guidelines, especially the one that came out recently last week, they don't recommending those as to be obviously the first line. They should be only used when there's really no option for basically using any of the other treatments. So either the other treatments are contraindicated or the patient really is not responding to the other treatment well. The next one is the adrenocorticotropic hormone. Again, it's coming up. It's in clinical trials for the purpose of acute flare. However, it's being used right now on a small scale studies. As effective as steroids and NSAIDs, it actually might have faster onset in terms of managing acute flare. Safety profile is really well, but again, it's not to be used as first line. And then clearly the two things those treatment modalities have in common is the cost. So definitely this should be something to be kept in mind when you make a decision about deferring patient to this treatment. So remember when we talked about the goals, so to achieve our goals of gout management, we have to control uric acid in order to prevent recurrence of gout flares and also to prevent joint damage. So who should be on urate lowering therapy or ULT? So the guidelines that 2020 guidelines, American College of Rheumatology, I think they listed specific groups there, and I've tried to summarize it for you. So clearly, if patient has a TOFI or subcutaneous TOFI, one or more, there's an indication for that. Frequent gout flares, defined by 2 or more in 12 months. Any imaging indicating basically damage to the joint or bone-related damage for attributable to gout is an indication for you starting urate lowering therapy. And this one is the last one here is the infrequent gout flares or even after the first gout flare, but the patient has to have some other comorbidities such as moderate to severe CKD and hyperuricemia or urolithiasis or kidney stones. So this is a conditional recommendation, means that there is some evidence, but definitely not robust enough to support this particular recommendation. But so you can see that sometimes you may see patients with acute gout flare first onsets, and then they might be on urate lowering therapy for this indication I mentioned. One of the biggest emphasis on this 2020 guidelines is the fact that we need to treat to target strategy. We're not treating to a fixed dose strategy. So that means you have to monitor the patient uric acid and you have to escalate the dose frequently in order to get to the target. The target for the treatment is less than 6 milligram per deciliter. That's our general approach for the guideline. And one thing about specifically with urate lowering therapy and in the context of CKD, I think a lot of physicians shy away a bit from using allopurinol in patients who have CKD because of the route of elimination. But those guidelines actually really highlight that this is urate lowering therapy, specifically allopurinol, should be used in patients who have basically stage 3 or more. Again, they have gout, but you should not deny them the treatment if they have chronic kidney disease. And then the last bullet point, which is an important aspect of minimizing the side effect that can arise from initiating ULT, is always start low and go slow. I think that's kind of true almost across the board, specifically with allopurinol to minimize the side effect associated with hypersensitivity reaction is you want to initiate the dose at a lower dose, and then you titrate the dose up until to a target dose. And the same goes for febuxostat. You start at a lower dose and you titrate up to the maximum tolerated dose or to achieving the target of serum uric acid. And important when we think about initiating urate lowering therapy, we have to keep in mind that we need to initiate also gout flare prophylaxis, because we know patients who initiate ULT, the chances of getting a gout flare is going to be very high. So it has to be almost a couple decision. When you make a ULT decision, you have to make sure that you're also giving the patient some prophylaxis as well. Generally, low dose NSAID or colchicine are preferred to be first line for gout flare prophylaxis. Again, systemic steroids could be an option as well, but second line, again, at the end of the day, it's about the patient and should be a patient specific. So although it's a second line, it may be the first line for some patients. Importantly to keep in mind is the duration of treatment, because initiation of therapy, sometimes the delayed onsets of gout flare can happen later on. So at least 3 months up to 6 months, and you actually can monitor the patient and you can extend the treatment even beyond the 6 months as patient reports gout flare. So some of the specifics associated with ULT, in this case, obviously allopurinol. So allopurinol is a purine analog, so it actually looks like a uric acid in terms of a structure. It's a xanthine oxidase substrate as well as an inhibitor. So it gets metabolized from allopurinol to oxypurinol. Oxypurinol is the active metabolite. It has the longest half-life for basically the drug, and it's eliminated by the kidney. And there have been some studies to show or the use of oxypurinol as a therapeutic drug monitoring approach, but we're not going to talk about that today. Initially, you start with a lower dose, as I mentioned, 50 to 100 milligram. 50 maybe for patients who have some sort of established CKD disease. 100 could be for patients who have normal kidney function. You titrate the dose almost up to 2 to 5 weeks until achieving target serum uric acid. Again, allopurinol is the gold standard for managing patient with gout. And side effect, as I mentioned, it could be related to the hypersensitivity reaction, but some other could be dizziness, rash, diarrhea, renal failure. And in some patients, I personally have seen is the urinary retention. It can develop as well. But the hypersensitivity reaction, I will talk about that later because that's probably the biggest concern with allopurinol. This is just a table to help guide you as you make a decision about starting allopurinol treatment. So in patients who have clearly established stage 4 CKD, you start with a 50 milligram with tapering dose of 50 milligram, and you titrate the dose every 2 to 5 weeks. In patients with normal kidney function, or obviously above 30 in this case, would be 100 milligram with, again, incremental dose of 100 milligram every 2 to 5 weeks. It's very important to mention that there has been data supporting the fact that initiating urate-lowering therapy during gout flare cannot or will not extend the perceived pain associated with gout flare. In fact, studies also support that initiating urate-lowering therapy during gout flare can actually improve adherence and can help patients to be adherent to medication. So this is an opportunity for us to really capture on and capitalize on to ensure adherence to urate-lowering therapy, which is already low. So going back to the hypersensitivity reaction to allopurinol, so there have been some specific risk factor for developing a hypersensitivity reaction. Again, initial dose, and that's why we emphasize starting on a lower dose and tapering interval should be on an extended side. Concomitant use of diuretics tend to increase oxypurinol level, and it can actually increase risk of hypersensitivity reaction, renal impairment. And definitely the biggest one is the HLA-B5801, which is a genetic biomarker that has a high predictive value for developing these particular disorders. And along the line of the genetic testing, which the guideline, actually the 2020 guideline made a new recommendation based on the prevalence of this particular polymorphism that African-American could be or should be genotyped for this HLA-B5801 before initiating allopurinol, beside the old recommendation of genotyping patients who have Southeast Asian descent. That could also be a recommendation because of the prevalence of this polymorphism in this patient population. And they also recommend against to genotype everybody, obviously. So that's important to highlight here. Febuxostat is our second line. Again, it's the non-purine analog, and it's probably not very similar to the structure at all of allopurinol. Start 40 milligram, and you titrate up to 80 milligram. And this one particularly does not have the issue of renal impairment, maybe really end-stage renal disease or very low kidney function. You might max at a 40 milligram, but you can still use febuxostat. Generally, febuxostat is reserved for patients who are not able to achieve the serum uric acid target with allopurinol, or they have contraindication to allopurinol use. Side effects from febuxostat are a little bit similar to allopurinol rash, nausea, arthralgia. The only one I think it's very unique to febuxostat is because of the route of elimination or metabolism, is you can see elevated liver enzyme, and sometimes it's probably a good idea to have baseline liver enzyme before initiating febuxostat. Unfortunately, with febuxostat recently, we've learned some not good news about it because it definitely can increase risk of death, cardiovascular death, and all-cause mortality, and that came from the CARES trial, which was conducted recently. But there was some preliminary data suggesting that, and that led to the fact that FDA issued a black box warning on febuxostat use in general, but let alone patients who already have established CVD event or comorbidities. And this is just from the study, the CARES trial, that really highlighted the issue of mortality associated with febuxostat relative to allopurinol here. And you can see those two important finding. The cardiovascular death was significantly higher in febuxostat arm versus allopurinol. And deaths from any cause, again, was significantly higher for febuxostat versus allopurinol. I know this is not a clinical trial lecture, but this study also had some limitations. So just to be able to be complete about that. So the study was a non-inferiority design study. So that, again, limit the interpretation a little bit. And there was no control group. So there was no placebo group in this study. This is, again, 2 comparators or 2 active treatment. And there was also a high dropout rates in the febuxostat arm. So again, it adds some complexity to the interpretation of the study. But again, the recommendation of using febuxostat as second line still holds true. So what do you do for patients who are still not being able to achieve the target with their febuxostat or allopurinol? What else can you do? Well, the good news is we have some alternatives, but some of them are not quite straightforward. So uricosuric drugs is the second line, or basically as an add-on to achieve your target serum uric acid less than 6. Losartan fenofibrate are, again, they're not a gout treatment, but they definitely have an effect on uric acid levels. Losartan is an antihypertensive. Fenofibrate is a triglyceride treatment option. And then we have the other drugs, lesinurad and then benzopromazine and sulfadiazole. They're no longer here on the US market. In fact, lesinurad just recently was removed from the market, so it was a very short visitor to the US market. It came in 2015 and it was removed 2019. From a more advanced form of gout, tophaceous gout, we have treatment option that pegloticase that can help you to basically resolve tophi if patient is not responding to the traditional treatment of urate-lowering therapy. So for propanacid, given that's the only one we have in the US, how we manage that or how can we use it, it's definitely a little tricky. So I thought it would be important to go over it a little bit more. So initially with propanacid, you want to start on a lower dose as possible. The guidelines suggest was a 500 milligram. You can start as a 250 milligram as well, twice daily for 1 week instead of initiating at a 500. And your maximum dose is 2 grams per day. It's important to increase the dose about every 4 weeks with an increment of 500 milligram to achieve that goal. So it's a tapering process, as we have been talking about the other treatment as well. With propanacid, it's so important and it's so critical to encourage your patients to be liberal with the fluid intake to minimize the risk of actually developing stone or basically urolithiasis or any kind of form of stone that might develop as a result of the uricosuric effect of propanacid. It's not recommended in patients who have creatinine clearance less than 50. However, there have been some studies suggesting that it could be used still, but clearly to avoid in patients who have less than 30 millimeter per minute. Patients who already have history of kidney stones is definitely not to use in this patient population, or who already have acute flare, definitely not to use in this patient population because it will make things worse. There's a drug-drug interaction with aspirin, so avoid those in patients who have aspirin because it will negate the effect of aspirin, propanacid. And then finally, the alkalize of urine. That was a long standard sort of approach to use when initiating propanacid. However, the guideline, actually, the 2020 guidelines, really are not suggesting that anymore because of the limited data or the strength of data is not robust to suggest that you should alkalize urine when you initiate propanacid. So like initiating the sodium bicarb or something like that would not be, it's not required or it's not recommended actually, but something to be aware of that was used before. So when we go to the next refractory case of gout, which is the tophaceous gout that's not responding well to urate-lowering therapy, we have pegloticase. So pegloticase is a recombinant form of uricase. So the uricase is an enzyme that humans no longer have. We have lost that gene about a couple million years ago. So only animals that have that gene, and that basically that protein that come out of that gene is the important for converting uric acid to allantoin. So this is the water-soluble one. Uric acid is not water-soluble. It's only approved, the pegloticase, for refractory gout, so not to be used as first line or to be used unless you really exhausted option of using the other treatment. Patients who have deficiency in the glucose 6-phosphate dehydrogenase are not recommended. In fact, you should avoid this particular drug with this patient. So people of Mediterranean descent or African American could be at high risk for having this particular deficiency because it can develop into acute hemolytic anemia or methylglobin. With infusion rate, because this is an IV drug, so there's definitely a risk of having anaphylaxis reaction that can result from this particular infusion. But the one that's probably more unique to pegloticase is the immunogenicity that develop to this drug. So the body can sometimes develop antibodies to this drug, and that could basically waste the drug. So the drug is no longer useful or effective anymore. And that really requires us to do serum uric acid monitoring before each infusion. So that's important whenever you use pegloticase. And the good news is also that we have seen, and we're seeing some case reports suggesting that use of immunosuppressive agent, such as methotrexate and calcineurin inhibitors, can actually mitigate this risk of immunogenicity and actually sometimes can reverse the effect of immunogenicity, and people can still get pegloticase. So as I mentioned, there have been a lot of options, and there's a lot of options for us to use for gout management, but the reality of gout is really poorly managed, and there's a lot of challenges associated with optimizing gout management. And just to kind of put something in there, I'm sure definitely the list can go on, but I found this to be the most important one. So there's a lot of heterogeneity around guidelines and practicing of gout management, and that again creates really some discrepancy about when to initiate your urate lowering therapy, and that could be because of different guidelines and different clinical practice. Initiating urate lowering therapy, again, in most cases is at least after the second gout flare, and sometimes could be even third or fourth. But is that too late for some patients, especially for younger patients who might have years ahead of them, and we are too late to initiate therapy? Again, there's a misperception of gout being an acute disorder, in fact, when it's a chronic. So that, again, changing the frame and the mindset around how we manage gout when we change that perspective, if it's actually a chronic disease like hypertension, like any other condition that you need to be on a medication long-term and indefinitely. Adherence to urate lowering therapy is probably one of the worst across almost chronic diseases. I think, I don't know the ranking, but probably about second or third below some other chronic diseases. So it's very low, just to bottom line. And then we know that because of the issues with hypersensitivity reaction to allopurinol, a lot of inertia around initiating allopurinol, or obviously escalating of the allopurinol dose beyond the 300 milligram is definitely causing missed opportunities to optimize gout management in our patients. And then finally, there's a lot of knowledge deficits among our patients with gout, because their understanding of gout is not quite, they don't have the right perception of the treatment and why they'd be on the treatment for so long, and also some knowledge deficit around how to manage gout from the provider's perspective. So that really begs the question, can we benefit from engaging non-physicians in the gout management approach? Well, the good news is that yes, we can. And this is actually one of two studies I'll talk about, is the pharmacist-led gout management, which was actually done in California, Kaiser Permanente healthcare system, really comparing two arms. One is the usual care, and then the other one was the pharmacist-led intervention. And the goal was to really look at how pharmacist-led can improve the desirable adherence to allopurinol, and also how many can achieve serum uric acid below 6 milligram per deciliter. So this is what the study, it was split of a 50-50 percentage between the two arms. And this table actually has a summary of obviously many other data, but I thought it would be the most important one for us to share, to talk about, is the usual care and intervention. So when you look at the serum uric acid levels less than 6, which is the target, 15% of the patients in the usual care arm achieved that goal. It's doubled in the patients who were in the pharmacist-led intervention. So clearly, there is an added benefit of engaging pharmacists in that approach. When we look at the PDC, which is a measure of adherence, you can see clearly that there's a significant difference in adherence. 37% in usual care achieved about 80% or more adherence versus 50%. And when we look at the total cumulative dose by the end of the study, which was about a 2-year study, I think, the length, it was 211 versus 237. So clearly, it shows that the pharmacist can do monitoring and can escalate the dose depending on the serum uric acid target. And the last slide, and also the last, for me, the last one I would talk about is the nurse-led gout management study, which was conducted in the UK recently. I think it's a very interesting study because it literally delegated the whole gout management to the nurse. So the nurse basically did everything, not just looking at the escalated dose. They managed the patient, they changed therapy, they initiated therapy, and the results from the study was very phenomenal. So just from the summary of the study, you can see definitely there's a high uptake of adherence. So patients were more willing to take medication versus the usual care. So the usual care was the traditional primary care physician, and then the intervention was the nurse-led. You can see clearly that the percentage of patients who achieve serum uric acid levels below 6, 95% in the nurse-led arm, 95% versus 30%. I think the numbers are screaming at us. And that's, again, this is very sustainable over 2 years period. And then all the secondary outcomes really were very in favorable of the nurse-led intervention in gout management. So clearly the message is that there's a role for non-physician to be involved in gout management. And I will hand the slides to Dr. Shah.
excellent review by Dr. Roman. I'm gonna briefly kind of talk about some specific conditions for treating gout. So patients, renal transplant patients. So these patients are at higher risk for gout due to decreased uric acid excretion through the allograft kidneys, and also the transplant medicines, especially calcineurin inhibitors, puts these patients at risk for gout flares. Other important thing in the transplant patient is you wanna, when you're diagnosing new gout, you wanna make sure to rule out septic arthritis, because these patients are immunosuppressed. So you wanna make sure there is no infection. And when you are treating gout flare in transplant patients, steroids are preferred, intra-articular if there is one or two joints, and systemic if there is a polyarticular flare. NSAIDs and very low dose of colchicine can be used with very close monitoring, but also depends on the renal allograft function and the time to the flare. IL-1 inhibitors is a good option in transplant patients if available, and other options are kind of contraindicated. I want to point out to one important drug-drug interaction here, allopurinol and imuran. They can lead to severe bone marrow toxicity, so avoid initiating allopurinol in patients who are on imuran for transplant. Hemodialysis patients. You want to use steroids for treating the flare in these patients. Avoid colchicine as it is non-dialysable. Short courses of NSAIDs okay for milder flare, but often there are other contraindications in these patients. They are on anticoagulation. It also increases risk of GI bleed. Pregnancy and lactation. Fortunately, we do not see gout often in premenopausal female, and even it's rare during pregnancy. But if you need to treat the flare during pregnancy, steroids are preferred. Avoid NSAIDs and colchicine. There's a limited data on allopurinol, so we try to avoid that. In conclusion, in spite of clear understanding of gout pathophysiology and availability of clear treatment guidelines, gout management is still suboptimal. And treat to target strategy to achieve uric acid goal is essential. Don't be afraid to increase dose of allopurinol even in patients with CKD. Patient education and shared decision-making is very important to improve patient adherence to treatment and improve gout management outcomes. Multidisciplinary approach with involvement of pharmacist or nurse should be utilized when available, and we looked at some of the very good data on that approach. Uncontrolled gout is associated with comorbidities and high cardiac mortality, and benefit of treating gout may confer benefits other than just reducing the gout flares. However, we do need some more guidance in this area into kind of what to do. Some consensus among different specialties is needed to improve gout treatment outcomes. Especially, we have different guidelines for American College of Physicians, in which treat for symptoms is okay for gout, versus we have a treat to target strategy for American College of Rheumatology. So we kind of need to bridge this gap and come to some common conclusion, as majority of patients are being treated by primary care physicians. I want to briefly talk about current projects and future goals for us at VCU. We have a project ongoing currently in which we are surveying rheumatologists nationwide to assess current practice patterns, barriers, and possible strategies to improve gout management outcomes. Josh, our first-year fellow, is working on this project with an amazing job. We have received about 159 responses from rheumatologists. We would love to extend this survey to primary care physician group, as a perspective of primary care physicians on gout management can be very helpful. As I mentioned, majority of patients are being treated by primary care physicians. So if any of you are interested, please to collaborate, please reach out to us for this. We have other project ongoing for assessing inpatient gout care at VCU, in which to understand the barriers of inpatient gout management, what happens after discharge, are the patients being seen in the clinics or not. And Yashvi and Evin are working on this project, and it's in a data collection phase right now. Our goal is to start a multidisciplinary complex gout care clinic at Now Center, which will be a pharmacist and physician-led efforts, in which the focus will be patient education, treat-to-target approach for gout management, frequent monitoring of uric acid, titrating urate-lowering therapy to achieve the goal. There will be a gout registry and coordinated research efforts. Our future projects will focus on pharmacogenetics in optimizing urate lowering therapy and gout treatment outcomes. We'll be looking at pharmacy-led intervention, education, compare that to standard of care, and looking at not just the gout-related outcome with the serum uric acid and the gout flares, but also looking at some of the secondary outcomes in which CVD events, cardiovascular risk factors, CKD, and some of the other comorbidities. Here are some of the references. Thank you, and we'll open it for the questions.
So I think questions have been submitted to the question and answer section. So let me ask a question from Sonja Fredrickson, if this is the format for doing this, who would love to hear your thoughts on the sodium glucose transporter 2 inhibitors that are used to treat diabetes. Can they, would they be preferential, for example, in somebody with gout with diabetic comorbidity?
Thanks, Dr. Schwartz. Thank you for the question. This is a great question. In fact, I'm writing a book chapter on this. Yes, we do have some exciting and really great data supporting that the use of SGLT2 inhibitors actually are preventing gout. And there have been data to show gout prevention, but also there's some data to suggest that specific like canagliflozin and some others, they actually can lower uric acid levels. So yeah, so that's a great question, and also could be a way to optimize drug selection, especially if patients have comorbidities like diabetes.
Another question from Bill Nelson. Can you talk a little bit more about the Stevens-Johnson syndrome and allopurinol sensitivity syndrome?
So I think, as Yusuf mentioned in the slide, that the patients, there are risk factors for developing allopurinol hypersensitivity syndrome, especially if you start higher dose, if there is a genetic marker for that HLA-B5801. So you kind of have to look into the high-risk population, look at the genetic markers for that. And the key is to start a low dose and titrating the dose up to prevent this side effect. And one other thing I would say that the prevalence or the incidence of the side effects is pretty low overall, in spite of, if you kind of carefully look into the high risk cohort. We actually had a project we did last year looking at allopurinol hypersensitivity reaction in the patients. We looked at the transplant database here and kind of looked into who had the HLA-B58 gene and looked into the side effects. So overall prevalence of the side effects was pretty low. So I think this shouldn't kind of hold you back in starting the patients who need it because of that.
To follow up on that, is it only in African Americans and Southeast Asians that you should do the typing, or is that HLA also associated in European ancestry patients?
So the prevalence of this gene in Southeast Asian cohort is about 7.4%. It's 3.8 to 4% in African American, and if you look at the Eastern European and Caucasian cohort, the prevalence is less than 0.7%. So the current guidelines do not recommend checking HLA-B5801 gene in the other cohorts.
So perhaps one last question. Is there any explanation why ACTH to treat an acute gout flare would have a more rapid response than steroids?
I'm not clear.
That's a good question. Honestly, I don't know the answer to that question. I think it's my understanding is there's a shared pathway of the monosodium urate induced inflammation that the adrenocorticotropic hormones act very closely around that pathway that allows it to work effectively. In terms of onsets, I I don't know. I don't know the answer to that question, to be honest. And it could be kinetics related, maybe. That could be another point to look into, but I don't know the answer to that.
But the data is for a more rapid onset of action is good.
Yeah, it's according to the limited data that we have so far, it has faster onsets than the traditional steroids or NSAIDs.
So I don't see any other questions. So I would like to thank you both for giving a very informative and fact-filled lecture. Well, we've got one more question, perhaps the last one that just came over.
Right.
That regarding febuxostat and safety in end-stage renal disease patients. Should it be considered?
Great question.
Dialysis.
Yeah, and I will take a stab at this, and Dr. Shah, please add to this if you want. So the good thing about febuxostat is the fact it's only metabolized in the liver. So UGT enzymes are really what's responsible for the metabolism and also elimination. Very, very small percentage of this drug is eliminated through the kidney, and it's not a reason for not to use it. You might probably not go up to 80 milligram in those patients. You might go up to 40 milligram for this patient, but again, it's not a reason to deny someone febuxostat because of end-stage renal disease. And Dr. Shah?
I agree with that.
Yeah.
Okay. Well, thank you very much. I think this ends our grand rounds. Thank you.
Thank you. Thank you.
Thank you so
Thanks,
much.
everybody.
Thanks, everyone.